Village. This is your weekly live talk show where community and support come together. With rotating hosts, expert guests, and meaningful conversations, we're here to guide you through the highs and the lows of infertility. Whether you're searching for answers, seeking advice, or just looking for a special place to belong, Fertility Village is your space to connect, learn, and grow. Because it really does take a village, and we are here for you every step of the way. Thanks for joining.
Hey everyone, welcome back to Fertility Village Live. I am Jess, one of your hosts. If you've ever been handed a genetic report full of letters and numbers, if someone's mentioned to you PGT-A, PGT-M, Mosaic, Euploid, carrier screening, you name it, and ever thought, what the heck does that actually mean? Tonight is for you. And if you didn't know, there's a whole profession built for exactly that, decoding all of the things I've just said. Someone who translates the science and walks you through your options. And tonight we'll hear from Emma Moore. I encourage anyone watching us to ask questions and to contribute however you want. We'll answer your individual questions as we go. And as a reminder, tonight is for you. Welcome, Emma.
Thank you. It's so nice to be here.
It's so nice to have you. I'm super excited to have you on. Love DNA, love Megan, love you. I'm so pumped to have you on and learn all the things about genetic counseling. Just a quick background on Emma for anyone watching. Emma's a certified genetic counselor with DNA, an independent fertility genetic counseling practice, and she works with patients through the whole journey, carrier screening before you start, making sense of embryo testing results, and the big decisions that come with them. DNA and Emma are kind of famous for taking the scariest looking science and helping you make decisions with full understanding. And sometimes those are really big, meaningful decisions. Emma, without further ado, I would love to know and learn more about you. Tell me about you and DNA.
Sure. So I am a genetic counselor. So I really, like you said, kind of break down this really complex information into understandable pieces so that people can actually make decisions with that information. I joke that I talk a lot with my hands, so I'll try to keep them down. But I use a lot of analogies. And as genetic counselors, we go to school and it's focused in like two ways. So we have like the clinical genetic side of things. So like learning all like the nitty gritty of all the acronyms and the science behind it. And then the other side is the communication. So like how do we communicate things like risk? How do we talk about uncertainty? And how do we do it for different people in different scenarios of different genetic literacy levels? How much exposure have you had to like a Punnett square in your past? So really kind of breaking it down at lots of different levels so that people can make decisions that are right for them.
100%. It's such a critical component of fertility journey. And I experienced some of that myself in terms of just trying to go through learning. I was a carrier of one type of disease and what that means for my husband and I. So like I'm just really excited to have you on tonight. When you think about a patient that books you, what are usually the most confused? What are people usually most confused or worried about typically?
Mm-hmm. Megan and I were just talking about this recently because we've actually seen a shift like pretty recently. It used to be like Mosaic embryos was the thing. So somebody had PGT-A results come back and they weren't really sure what to do with them or how to understand them. And now we're seeing it shift to like really like aneuploid results, especially if there's just a problem with a part of that chromosome for that embryo, where it's still such a new thing and things evolve so quickly that I think a lot of times patients just want to come in and say like, what do I make of this? What do I do with this? Is this okay? Is this not okay? And I feel very lucky because I think in a lot of those situations, I get to be more reassuring. And so people often come in very worried. And a lot of times I get to say, oh, hey, like, look at this, look at this, look at this, look at all these studies that have been done recently. And it really can be very, I think, empowering to have that information.
Absolutely. Absolutely. What is, if we talk about kind of the basics and before you make an embryo, what is carrier screening and what does expanded carrier screening add?
So carrier screening is super helpful to look at a list of conditions that we usually don't know about ahead of time. Like there aren't any clues in the family history if somebody like carries a genetic condition. They're usually very sneaky. An analogy that I like to use is it's like having a toaster that only works on one side. Not a big deal. You can still make toast. So for most people, they don't notice big effects. I also like to say that like if every time somebody was a carrier, their pinky finger turned bright blue, be way easier because we could track it through the family, right? But that's not the case. And when we think about expanded carrier screening, this helps us to get a much broader look at a lot of different conditions. So like the standard minimum, bare minimum is like 4 conditions. And now when we're thinking of expanded, we're thinking of about 300 up to even 800 I've seen more recently, which, there's a whole debate point there about how far is too far, but we are seeing it expand over the years.
Amazing. Is that a result of, and this might be a very naive question, but a result of just expanded understanding, expanded science around the specific profession?
A lot of it is we're learning more. We have better technology. We can look for more things at a less expensive cost. So it like is more beneficial for patients. It's more likely to be covered by insurance, all those fun healthcare things. We are also seeing that I think people are willing to kind of broaden the circle of what they're thinking about. So, like more conditions that have been added more recently have looked at things like being born deaf or part of the deaf community with that hearing loss. Is that something that should be included or not? So, as the circle of conditions expands, we see more conditions that may be different than the like life-threatening, significant concerns that we sometimes think about.
That makes a lot of sense. And if both parties are or carry the same thing, what does that mean for their odds and their options moving forward?
Yeah. So people being carriers of the same condition is not atypical. We see it like 1-ish% of the time, but I will say like that sounds so small until you think about like all the people worldwide having children at any time, right? Or egg and sperm combining at any time. So when the egg and sperm are both carriers of the same genetic condition, that's not a stop sign. We have options that we can go through from there. So some people say like, oh, cool, now we know. I don't really want to do anything with that information. Some people say, I want to continue on my journey, whatever that looks like, and maybe we'll test during pregnancy, maybe after a baby is born. Sometimes people say, hey, let's do embryo testing. And that's that PGT-M that I think we're going to probably talk about in a few minutes.
We will, totally.
Yeah. So the PGT-M lets us say like, hey, let's look at the specific condition in the embryo. And that helps us to prioritize which embryo to transfer depending on that couple's goals.
Amazing. And if one partner is a carrier of something and the other partner is not, how does that impact decision making going forward, if at all?
Yeah, so I would say usually in those scenarios, it doesn't impact decision making. I say usually because there are some conditions where being a carrier can have a significant health impact. And in that case, we would maybe make different decisions based on that, carrier status. When one person is a carrier, they have a 50% chance to pass on that carrier status or not. And we don't really have a good way to control that. We can't like whisper to our egg and sperm, like, hey, can you pass on this or this? So in that case, we would sometimes do additional investigation, but that's really the exception, not the rule.
Okay. And then as I recall, and I again could be totally off base on this, when you get your carrier screening testing, you find out if you've got 1 copy or 2 copies of something, if anything at all. What does that mean?
Yeah. So we all have 2 copies of our genes because we get one from the egg and one from the sperm. Sorry, I have a puppy. No. Sir.
So cute. No problem.
So 2 copies of our genes, one from the egg, one from the sperm. Usually, carrier screening tells us if somebody is a carrier, that means there's a problem on one of them. So a lot of times a report will say like positive for A, like variant, which would mean like, hey, there's an impact on one of them. Rarely we do see that people can have problems on both sides and they may actually have that condition. That's not what carrier screening is designed to do. We're not trying to diagnose anybody with anything, but sometimes it does come up just as people are learning more about their genetic information.
Amazing. Yeah. I find it so fascinating. Like it truly is such a complex science. And another kind of question for you, what should someone ask their clinic before their IVF cycle that most people don't necessarily think to ask about?
I think carrier screening has become a lot more standard for many clinics now. I do recommend carrier screening just based on national guidelines and based on personal experience. I think that information can be really jarring if you learn it like during a pregnancy or as a part like of going through like IVF. Like a lot of times it can kind of throw people off their game. So having that prior can help them to be prepared as they're going through. They already have that information. They've kind of understood it and assimilated it into their kind of understanding. I'm becoming a bigger and bigger proponent of pre-test counseling for PGT-A testing specifically.
Interesting.
I think there are so many nuances that it's become kind of like a standard recommendation where like, oh my gosh, so many clinics, especially in the United States, will do that testing just kind of as a default. And the more literature that comes out, the more we are starting to question, like, should it be the default? Is it truly beneficial? When is it? When isn't it? So I strongly recommend having that conversation with your clinic ahead of time about like, is this the right fit for us?
I know we're going to get into it, so I won't talk more on that, but I've seen that topic come up more and more of is PGT-A or is further testing or testing before you know something necessary. So speaking of which, if we switch to the alphabet soup, I like to call, so to speak, because it's all these acronyms and then different add-ons to the acronyms. Can you give us the like general map of the PGT world at least?
Sure. Okay. So PGT stands for pre-implantation genetic testing. So we're looking at an embryo before we transfer it. This is done after the egg and sperm come together. We're trying to get information of that embryo. When people say PGT, usually what they mean is PGT-A. So this is looking at like big chromosome differences like Down syndrome, where somebody has an extra copy of a chromosome or a missing copy of a chromosome. We call this aneuploidy, which just means like abnormal number of chromosomes. So that is kind of the most common one. As we've kind of touched on, it's becoming a lot more standard there. So when people say PGT, that's usually what they mean. There are two other types of kind of well-known but not as widely used testing. So there's PGT-M, which we mentioned earlier, like if people are both carriers of the same condition, if there's a genetic condition like a BRCA mutation in the family, people can do embryo testing for that specific condition. It's really a narrowed in view to say, hey, we're looking at this one thing. M stands for monogenic or one gene. So that helps us to kind of really narrow in there. And then the last type is PGT-SR. So SR is structural rearrangement. This is kind of a weird term, but essentially just to say like sometimes people have differences in the way their own chromosomes are put together. Usually doesn't impact them, but it can impact what the embryos look like in terms of the chromosomes when they come together. So that is something that can be helpful for people with a chromosome change in the family.
Is that when it does actually? I just learned something new on that too, because we did PGT-A testing. We didn't need PGT-M, but the SR structural what I forget the
rearrangement. It's okay.
Thank you. Structural rearrangement is totally new to me. So when you say PGT-SR, does that pull out something that I hear across the fertility world as like a balanced translocation?
Great question. So that's exactly what PGT-SR is designed for. So the balanced translocation means that these chromosomes are kind of like switch places, or maybe one is on top of another one or glued together, something that just impacts how they're arranged. And chromosomes are kind of like bookshelves of information. So if I have two bookshelves that are stuck together, no big deal. I still have enough information. I still have what's supposed to be there. But these chromosomes are supposed to split to go into the egg cells or the sperm cells. And say one's on top of the other one, it's a lot more likely that when they split, there's going to be this imbalance. So PGT-SR is saying, hey, if you've got a balanced translocation in a parent, is there an embryo that is imbalanced? Because
Okay.
unfortunately, that's why we can see a higher likelihood for like pregnancy loss for somebody with a balanced translocation, because the embryos are just more likely to be abnormal. So sometimes that testing can help us to prioritize an embryo that has a better likelihood of resulting in a baby.
That makes a lot of sense. Okay, I'm going to go off my questions for a second
Yeah.
here on this topic, because I know I've seen people talk about having a balanced translocation, or how do I know if I do or I don't.
Yeah.
First question would be, how is there like things that you've talked about or worked with people to know if and when they've had a balanced translocation? Is there clues to look into it? Just the general, like, at what point do you even, is this something you typically know about yourself?
Yeah. So I think a lot of people, kind of like we talked about carrier screening, a lot of times they don't know. They may start to kind of do the investigation as they're going through any sort of infertility or subfertility journey. Usually we see when somebody has a history of 2 or more losses, that's when we recommend looking at their chromosomes under the microscope to see if there are any differences. And that's again based on like national recommendations. I always kind of, when I'm talking to somebody, one kind of standard thing that we do is kind of talking a little bit about like the history. Have there been any pregnancies in the past for you or for your partner? What about the family? Is there any history of multiple pregnancy losses, but also things like stillbirths, infant deaths, or early childhood deaths? Those can also be little clues that can help us to look at a picture and say, maybe there's something going on from this side of the family, for example. Sometimes it's coincidental, but sometimes it is a relationship to those chromosomes.
That makes a ton of sense. It seems that as kind of you're talking, what comes to mind is that family history or medical family history or family history on either side in terms of
Yeah.
their reproductive health history would be
Mhm.
really critical in terms of the genetic kind of clues to look into stuff.
I absolutely agree. And I think it's challenging because, I mean, I think it's gotten a lot better, but especially in previous generations, like talking about things like pregnancy loss was like very taboo. And I tell people all the time, like, I'm a genetic counselor. If you ask me about my grandmother's history, I couldn't tell you. Like, if you ask me when she passed, I'm like in her 70s. I don't know why. Like, we always do the best we can with the information that we have. And the
Yeah.
most important thing is going to be your own history. That is going to be kind of the biggest indicator there. And because of American health insurance, also the biggest indicator of like how much is that testing going to cost? Because
Yeah.
if you meet those criteria, it's way easier to kind of pursue that chromosome testing. Oh, and I always want to mention, if a couple has a history of multiple losses together, I want to test the egg side and the sperm side. Sometimes people will like by default just test the egg side, but like the egg and sperm both have chromosomes. And so I want to look at both sides to make sure we're getting that full picture.
That makes a ton of sense. Okay. And on the basic sperm testing, like the morphology, motility count, is there anything in that basic testing that might say, hey, you should maybe do some further genetic or carrier screen testing?
Mhm.
Okay.
We do a little less, I think, with sperm morphology, depending on like the clinic that you work with and the context and things like that. But generally, when I see a like concern, it would be like no sperm, azoospermia, nothing in the sample, because sometimes that can
Yeah.
be because of a chromosome condition like Klinefelter syndrome, for example.
Mhm.
Sometimes it's because of a blockage, in which case maybe we're thinking of like cystic fibrosis carrier status. So we'd go down that way. And then sometimes there is a genetic condition where the tail of the sperm isn't made in quite the right way, and so it doesn't swim very well. So sometimes that can be because of that other condition, but usually there are other signs there. It's not like just one thing we're looking at there. We're looking at the constellation of everything together.
Amazing. And do fertility clinics typically, or some fertility clinics, point their doctors point their patients to say, you know what, you should probably have a conversation with DNA and just dig into something here, at least talk to them about potentially digging in?
We do have definitely some clinics that will say like, hey, like I think you would really benefit from talking to somebody in more detail about this. We have the time, we have the expertise to really walk through everything in a ton of nuance.
Yeah.
We also have a lot of patients that seek us out independently and say like, hey, I have been looking for these answers and I was Googling and your name came up. Like, what can you tell me about this? Messages on Instagram, like on the website, like
Totally.
it happens in lots of different places. I'm just happy when people find us because that's my favorite thing to do is to talk about all of
I
this.
love it. You guys are so awesome. I 100%. Okay, PGT-A checks the number of chromosomes. We talked about kind of who it's for, and it's something they can do. Is more testing always better, or where do you see patients test more than they've necessarily needed to?
Yeah, it's a great question. And I think it's always the answer of like, because we can, should
Yeah.
we, right? Like where do we draw the line? And that line is going to be different, I think, really for each person, and sometimes in different cycles, even for the same person. So I've had patients in the past where they start and they do PGT-A, and then they go through and find out like, hey, they had mosaic embryos or segmental embryos, and their clinic said we're not going to transfer those, and that sucks. So the next cycle, maybe
Yeah.
they say we're not going to do it, we'll just use like, how does the embryo look under the microscope, like the grading, more so than the
Yeah.
PGT. This is kind of a side tangent, but there's also a new type of embryo testing that is trying to look for things like heart disease and cancer and like diabetes. And it's very like sci-fi and like almost like Gattaca, this old movie. But it also is like so I think right now it's making promises that it can't live up to as of yet, just like where the science is. But it
Yeah.
made me think of this like, just because we can, should we? Like, where is that line of like, what is enough information? What's not enough information? There have been a lot of lawsuits in the last couple of years,
Yeah.
specifically around PGT or PGT-A. And I truly, truly feel that not all of those concerns, but some of them would have been helped if they had had a conversation either with a genetic counselor or somebody else about like, what can we learn? What can we not learn? What do we do with
Yeah.
these results? What are your clinic's policies? Like, if they won't transfer any mosaics, that's important to know. Maybe that
Yeah.
is your deciding factor of like, oh, no. If they'll transfer anything, that also probably impacts your decision making.
Yeah, I really wanted to hammer home on that with whoever's listening or going to listen to this. Is I had no idea about clinic policies before I decided to PGT-A test our kind of first IVF round. And I've heard of a few situations where, someone came back with all high level of mosaic or abnormal embryos and basically had nothing that their clinic would transfer. So can we just like walk back to the 101 of like, okay,
Yeah.
what is the different results that you can get effectively from PGT-A, and then and then we can talk about the kind of clinic policies that everyone listening should be aware of.
Yeah, for sure. So I think, we used to have this kind of very binary understanding of embryo testing. It was like normal or abnormal, and like that's it. And it was a very straightforward discussion then. Like if it's normal, good to go, can transfer. Not a guarantee for a healthy pregnancy, not a guarantee of a baby without any like differences like a heart defect, but the most likely to get us to that pregnancy. And then we had aneuploid, where that likelihood is not zero, but pretty close to zero. And so it was very straightforward. And as we started getting this kind of like development in technology, we also saw this development in complexity. So the way that I kind of think about it as like a quick rundown, Euploid, normal. Euploid, and there's mine. Euploid is abnormal. And then Mosaic is mixed. So just like we see like a mosaic tile, like sculpture, right, where there's like a mixture of different types of tiles, different sizes, mosaic embryos have a mixture of some normal and some abnormal results. And so those are kind of, I think, the big three. When we start to add in more complexity, it's about like, is it a high level or a low level mosaic? So is it more normal cells or more abnormal cells? And then is it a problem with the whole chromosome, like chromosome 5, for example? Or is it just a problem with like a part of the chromosome? That's called a segmental, because it's a segment of the chromosome. A lot of new research is coming out about segmentals at this point. So I think we're going to start seeing chatter about that a lot more.
That's fascinating, because I will go to the clinic policy in a second here, but one of the things, actually, no, I'm going to go there and then I'll walk back to my kind of second question. Sure. So I've learned, and I almost learned after the fact, wish I would have known, that every single fertility clinic has a policy on what they will or what will not do with PGT-A results or embryos and transfers. Can you talk about how and what that has on an impact on a patient and things they should know or ask the clinic in terms of, like, for example, do they discard the abnormal embryos right away before you even have the chance to say, I want to transfer them someone else? Like, just stuff like that.
Yeah, no, absolutely. I think you bring up a really good point of like, what is the plan, like right after we get those results? So like, if they're abnormal, are they discarded? Can we keep them in storage? Sometimes people want to talk about like a compassionate transfer where they transfer it off cycle. There's so many different ways that people feel like ethically about embryos that have been created. And so I think having that information at the beginning helps you to know and to potentially say like, hey, that's not the right call for me. Like, can we put these in storage, for example? And also, like, what does the clinic use to say like where they draw that line of like what's abnormal, right? Where do they say, hey, this is our boundary? We'll transfer low level mosaics, but not high level. Or we'll transfer any mosaic unless it has Down syndrome in the result. Like a lot of times clinics will have specific policies about embryos with something like Down syndrome or something that we like know a lot about. There are studies coming out about that as well. Like, is that a line that we should be drawing? Are we being overcautious? Is the data limited? So that is a piece as well. And I think sorry, go ahead.
I was going to say, it really does lean into the philosophical approach to some of these conversations too. Yeah, I had no idea even the clinic could be, their decisions could be nuanced outside of just abnormal, low level mosaic, high level mosaic, or euploid.
The like increase in complexity, I think, has been a debate in like the genetics and embryo side of things for a while now of like, is the increase in complexity helpful? Like, are we actually giving people information that is helping them make decisions? Or are we creating this like confusion with clinics? Are we creating all this kerfuffle where like maybe that's not actually what's most helpful? And of course, like, we don't want to be paternalistic, right? Like, I'm never going to tell somebody what they should do or shouldn't do. But we have seen that like a lot of times by the time people get to embryo creation, we are like well past decision fatigue, right? Like, people are tired and they're tired of making decisions and tired of trying to figure out what they should do for next steps and trying to prioritize different things. And now they have, like you said, this like alphabet soup of all these different results. What do they do with this? It's exhausting. For some people, more information is power. And for some people, they say like, hey, like, that's too much for me right now. And that's totally fine.
So can you describe, how does someone in this situation that they've decided on PGT-A testing, at what point do they, let's say they haven't engaged with you guys yet, how do they typically engage with DNA or a genetic counselor in general? And what does it look like to sit there with someone and say, like, coach them through or support them through or explain to them? I've never experienced it, so I'm just curious. I'm sure others are, on how do you walk them through it?
I'll speak for me personally, like my own process. Everyone's got like a little different style in terms of like genetic counseling. I always want to start with like, what do you know? What do you like? How have you learned? Have you gone on to any like Facebook pages or Reddit pages, or like, did you put your results through like ChatGPT or anything like that? Which, caveat, I don't recommend because of like privacy concerns. And because like AI tools, a lot of times they pull from the wrong data set for embryos. I'll do like a test case every now and then, but we're just not
Yeah.
quite there yet. So I always start with like, what do you know? And what are your big questions? Like, is your question, can I transfer this embryo? Is your question, if I transfer this embryo, am I signing up for a baby with a chromosome condition? Is it right or wrong to transfer this embryo? Which, of course, is not my call, but we talk about like, what do you feel about that? What do you feel about uncertainty and risk? And what does that look like in your life? Really kind of walking through how can we bring these pieces of information together to make a decision that's right for you. And like, I'm never going to tell somebody what to do. And I think for better or worse, like some patients really want that. They really want me to say like, tell me what to do. Tell me how to rank these, tell me what's most important. And a lot of times, like I've talked with these people kind of face to face for like less than an hour. I'm like, I know you this much, but you know you, and you know what you're comfortable with. And if I'm saying something and you're like cringing away, like that's telling us something.
Yeah. It seems like really like there's a lot of, I'm trying to put myself back into even when we had 2 low-level mosaics and 1 high, was like, I don't even know how to understand what the risks are or what these like complicated embryology report and PG report words mean. And in order for me to make a decision, because I'm trying to make all these decisions, like I want to understand. And it feels like, kind of going back to the introduction of DNA and genetic counseling in you, Emma, is taking some very complex topic and science and trying to boil it down to like, not only what does it mean in plain terms, but what are the risks or what are the chances, roughly, you never know. And then I love the fact that there's an emotional or a like look within yourself and look within you and your partner and have a conversation about it.
It's what made me fall in love with genetic counseling. Is I love the science, but I really wanted to work with people and talk with them and really kind of help them explore with that knowledge of, okay, now that we kind of understand what the heck this report is trying to say, what do we do with it? Do we do anything with it? Do we put it on the back burner? Do we put these in storage? Do we now feel comfortable discarding? Like, there's so many different paths that are available once we kind of have that context and have that background. I don't think it helps that reports are also written differently from different labs in different years. And so like, even if you're trying to like cross compare or like look at others' reports, like sometimes it's lingo and it's not helpful unless you know the lingo.
Which actually I just thought about too, because if you, let's say like I've got embryos from 2020, still frozen, low level mosaic, what the designation might have been in 2020 could drastically change based on new science in 2026 as well, I'm assuming.
A lot of times it's about like, sometimes like different labs had like a slightly different technology approach, or like they didn't report certain things at that time, or they didn't have this like testing platform. And like, unless you happen to have talked with like the lab genetic counselor working with that, PGT testing lab, sometimes you may not know. A lot of times what we're seeing is like, as we have people that are more comfortable transferring different types of results, that also gives us a lot more data. Way easier to look at trends of 5,000 embryos versus 50 embryos.
Totally. And if we look at kind of the mosaic and Euploid, or the mosaic and abnormal side of things, one of the things that I read somewhere, I cannot tell you where, was that there's not even enough science to know if an embryo can correct itself in utero or in the womb, trying to figure out the right terms. But Can we just talk about that? Because that has got to be such a mind-boggling thing for someone to like then think about that and make a decision, or even just for the clinic policies around this, if we just don't know if things cannot correct themselves.
I will try really hard not to get too jargony, but this is one of my favorite things to talk about and to learn about, because when we look at embryos, we have seen in the lab that they can self-correct. I don't the term self-correct, I have a personal qualm with because I just feel like it sounds like here's this abnormal cell and it's going to fix itself and turn into a normal cell. And what we really see is like it's a population of cells. So like an embryo is like 200 cells, right? And if some of them are abnormal, then the question is like, are they going to be kind of outcompeted by those normal cells? Are they going to die off at a faster rate? And we do see that. So we've seen that in human embryo studies when donated embryos are allowed to grow until like day 9 or 10 in the lab. And we see that the level of abnormal cells, they die off at a much faster rate than we would typically expect. We see this in mice embryos as well. There are some really cool studies out there where they like light up these different parts of the embryo based on this like fluorescence. And so we can see them die off in pictures over a time frame. What's also really interesting is that as an embryo is developing, one thing we think might be happening is that if there's a mutation in some of the cells, as the cell is, or as the embryo is developing, those abnormal cells get pushed to the outside, which is great for the inner part of the embryo that could become a baby. But for us, where we're taking a handful from the outside of the embryo, maybe we're just happening to grab part that's abnormal because of this like normal process that maybe happens for a lot more embryos than we previously thought.
I have that on my like list as we were talking of, we have to remember with this PGT testing that it's a biopsy of one portion of the embryo. Mm-hmm. And that's fascinating that there's that new science or theory coming out that pushes to the outside. I always wondered, and self-correct is totally my way of like explaining to you what I was complicated.
Everybody says it like that. I have not come up with a better term. I just like to talk through it about like, what are we actually like picturing here?
Okay, now I'm going to go down a total different route here. You can tell me if we can redirect on some of this stuff. So I remember, and I still still kind of talk to friends or trying to like just talk with people about, the IVF process. And there is the concept, as I remember it, of like a day 3 transfer, a day 5, a day 6, or day 7. And some clinics will only let an embryo develop to day 5 or 6. Some go to 7 or more. But then I'm just learning from you, like we have seen that self-correction or dying off or whatever on later ones. I just love to talk about, I don't even know what my question is, but I'd love to learn. I'd love to learn from you in terms of that. Is there any correlation, I guess, between days that you stop an embryo developing before transferring in or freezing and genetics? What genetic results, PGT-A? Yeah.
No, I think it's a great question and like just a great topic in general. So like we used to test embryos on day 3 almost universally. That was like the norm. And now we've shifted to mostly testing them on day 5. But for some people, for reasons we don't totally understand, their outcomes are way better if we transfer a fresh day 3 embryo versus a normal tested day 5 embryo. So like maybe for some people, or maybe there are some characteristics in cases where like maybe a day 3 embryo has better outcomes for a certain population. I also find the day of development to be really interesting because we know that day 5 embryos tend to do a little bit better than like day 6 or day 7, but that's not universal. So like we can have a day 5 embryo that gets like, gold stars across the board, and maybe it doesn't implant. And then we can have a day 7 embryo that is like maybe like a last shot and it turns into a healthy baby. And so like it's not so much as like a clear dividing line in a lot of these cases, but a like, how can we bring all these puzzle pieces together to try to prioritize in the best way that we can? Did that kind of get at what you were asking?
It totally did. Yeah.
Okay.
Yeah. I thought about that too, because you're kind of like taught, at least I thought I was taught that, you know, the longer it goes past day 5, significantly less chance. And then I had a day 5 something AB, I had AB, day 5 AB embryo not work. And then I had another one initially work, but then miscarry. On, and trigger warning for anyone listening, on the miscarriage side of things, I post miscarriage learned that you could test the retained products of conception. Is that something that people can then work with you about understanding those results?
Absolutely. And it's something that I think is a very tricky topic for a lot of people, not only like emotionally, right, but also like logistically, doing that testing, financially, like who is doing that genetic testing, and then, you know, what do we do with it? So there's a study recently that came out that said that maybe for some euploid or normal embryos that miscarry, maybe that's because they have a small genetic problem that we couldn't see on the embryo testing because it's just not that detailed, because it's a really small problem. And so I think sometimes that like testing or that POC testing can provide some level of closure for some people about like, oh, hey, like this is kind of what we think happened. Or alternately, like this didn't happen. Like, hey, we thought it was a mosaic embryo. We transferred, the POC tissue was normal. Okay, that tells us that it didn't stick around. It's still a bummer because we don't know why the loss happened, but just to kind of have that, a little bit more of that understanding piece. For some people, it's great. And for some people, it's opening up a rabbit hole where they say like, I'd rather not. And again, no right or wrong decision, but it is absolutely something that we work with patients with DNA.
I had no idea that even existed before too. I think it's a wonderful option if you want to do that. I would love to talk about age and just decision making around doing genetic testing, or how age impacts genetics, because we hear, you know, the older you get, the more likely you'll have an aneuploid embryo if you were to genetic test. Just how do you talk to people about this, or what should we know as fertility patients?
One thing that I always want to emphasize is like, it's nobody's fault. And we know that it is starting to be discovered from the sperm side of things as well. So I think with a lot of fertility things, the onus is on the egg side, but it's absolutely an interaction of those things coming together. And we're continuing to learn more over time. So we used to think that everybody with eggs was born with the eggs that they've got, and that's what they use throughout their lifetime. And now there's some murmurings that like maybe we actually make new eggs, which is like mind-blowing. So when we think about age, the way that I use it in conversations is to kind of help guide some of that decision making. So for somebody who's in their late 30s and they are considering if PGT-A is the right choice for them, and one of their big concerns is pregnancy loss, then PGT-A testing might be the right choice for them. And somebody who's in their late 20s or early 30s, well, the data is not quite there. That data doesn't really support like necessarily a lower likelihood of pregnancy loss or change in the live birth rate over time. So it's really kind of saying like, what's important to you? What are the other factors that we know about? And how can we make a decision that feels right for you? And again, that may be different from cycle to cycle. I also have a qualm against like AMA, right? Like over 35, like especially when we're thinking about testing during pregnancy, like carrier screening, it's the same. The like blood test during pregnancy, it's the same recommendation. Ultrasounds, like there's so many similarities across different age groups now, and so many people are having babies in that time frame. So like I want to do less of a like, here's a bad thing your eggs are doing, and more like, okay, like here's information that we have, and we know that that can happen at any age. And in fact, there's a spike in your late teenage years and early 20s where that abnormality is also very common. So we see this like dip in the data where like it's pretty high early 20s, dips down, and then like mid 30s-ish it starts to slightly increase over time. So it's really kind of more of this like wave that we see in the data. So again, it's a tool. It's a piece of information that we can use.
Yeah, I love that approach to you see things at different ages, because you hear, oh, after 35 there's just a massive clip in your fertility, like basically your chances are plummeting. And we know that age has an impact, absolutely, but
Sure.
there's an element of hope or understanding or informed decision making versus that, like you're saying, that scary thing that's coming at you as in your next birthday.
Yeah, no, absolutely. And I think there's kind of this perception of like you turn 35 and this like switch flips in your body, and like before 35 the eggs are all normal, the embryos are all going to be normal, and then after 35 they're all going to be abnormal. But it's like an individual roll of the dice each time the egg and the sperm combine, and we see that at every age. So like I cannot think of a single embryo report that I've seen where they are all normal. Statistically, just so unlikely. I'm sure
100%.
somebody has it. Like I'm sure it's happened. It's just not something that I've personally seen.
100%. One thing that I wanted to dive into a little bit is, we talked about this, I think, a little bit, and if we've already touched on what you think is the main answer to this, we can skip through it. But what is something that most patients misunderstand about their results?
That's a really good question. I think the most common perception that I see is that Mosaic embryo has a high likelihood of a baby with that condition. So like if an embryo is Mosaic for a problem with chromosome 7, like an extra copy, then a lot of times when they're coming into the conversation, one of their first questions is, what's the risk? What's the likelihood that I would have a baby with that condition? Which is understandable. For individuals with chromosome differences, we often see things like intellectual disability, developmental delay, heart defects. Like there's a lot of different things that we can think of. So I think that's one of the big topics is like, if I transfer this embryo, am I doing it with this high risk for health concerns for a future child? I think that is something that like ethically people sometimes really struggle with. And so this is, I think we mentioned this earlier, like I love getting to be the person that like potentially can give them some hope about like, oh, hey, like here's what we've seen. Is the risk 0? No. Is the risk ever 0? No. Right now we say that risk is like about 1%, and we keep learning more about that over time, and I'm sure we'll get to a point where we can like say specific, like, oh, low level for this equals this, whatever. We'll get there. But really being able to say like, this is not a guarantee. It doesn't make you a bad person to roll this dice. Whenever egg and sperm combine, we are rolling the dice. A euploid embryo could result in a baby who, as they're growing up, has a speech delay or a developmental disability, right? Like there's no guarantees, even with the most perfect, quote unquote, of embryos. So really trying to conceptualize that background risk and saying like, what is the actual risk of a mosaic embryo? I think that's probably the biggest thing that I see.
That makes a lot of sense. I love that answer, because you're totally right. You think about what's on the finality of what's on the report is what's going to happen, and there's so much to it. Yeah.
And I think,
go ahead. Sorry.
I was just going to say, thinking about all these like lawsuits and like developing technology and things like this, I think what I've also seen is like patients being like, okay, so like, why do we even do it? Like, what, like, there is a false positive or a false negative possibility. So like, why the heck would we even ever trust these results, right? And when we get like a euploid result or like a fully aneuploid, say there's like 3 different problems with the chromosomes, then the likelihood that that predicts the inside cells of that embryo, like that biopsy is a much better predictor. It's like 98% of the time. And so for certain cases, that PGT-A testing can still be really helpful for that specific embryo. We're just not, in genetics, we never say always, never say never, right? So like we know that there are limits to technology. We know there are limits to an embryo biopsy. For some people, that testing is still worth it. And for some people, those limitations are enough to say, no, actually, that has pushed me to the side of like, no, I don't think this is going to be a helpful tool for us at this point, which I just think is so fascinating.
And is that the same? Is that the same for like the 2% chance or the whatever of PGT-M and PGT-SR?
Great question. A lot of times that is the number that they quote for like the likelihood that it's wrong. And that is where that is based of like, what is the likelihood of agreement or concordance between the outside cells and the inside. And that's why like after somebody does PGT-M, PGT-SR, and truly even PGT-A, the current recommendation is to do an amnio during pregnancy for confirmation, which that's a whole nother can of worms that we probably don't have time to dive into today. But just to say that like for some people that's the right choice, but for many people, in my personal experience, I've seen that like once we get to the pregnancy stage, we've fought so hard to get to that pregnancy stage that introducing any risk for many people is a no-go.
Yeah, I could totally imagine that 100%. That amnio side of things, I think, would be a fascinating second conversation, because I can imagine that's much longer than the 7 minutes we've got left.
Yeah.
Out of curiosity, because you have so much, like a wealth of knowledge, you've talked to so many patients. Is there anything else that you feel for anyone listening that you just want people to know about, or that I haven't covered in the questions I've asked you?
You've had such good questions. I feel like we've dived into so many things.
We totally have.
I think we've kind of touched on a couple of the things of like, there's no guarantees, that there's this background risk, that embryo testing is, for PGT-A specifically, it's just meant to get us like to the pregnancy stage. Like that's the goal of embryo testing, not necessarily like a baby being born that like doesn't have any differences, right? So like we're just trying to get to that stage. And then I think I would want people to know that if they are in the group of people where multiple types of embryo testing might be helpful. So say they're doing PGT-M and their clinic says, well, let's do PGT-A as well. The more things we add on, the more challenging it can be to prioritize those embryos. So like PGT-M, say we're looking at a condition where egg and sperm are both carriers, there's a 1 in 4 chance for each of those embryos, right, to be affected potentially. And then PGT-A, that's that roll of the dice when the egg and the sperm come together. Are the chromosomes normal or not? And so sometimes I've talked to people who want to do PGT-M for multiple conditions. And then we have a conversation about like, okay, given age of the egg side and sperm side, given these conditions, what are we anticipating? Because if we have 20 embryos, maybe that's reasonable. And then we can actually hope to have some usable embryos. But if we're not expecting to have a bonkers number of embryos, sometimes doing multiple layers of testing specifically for PGT-M may be less helpful. I also find it's a conversation about like carrier screening results. What do they actually mean? Are you really a high risk couple? Are these mild mutations? Like really having that additional context, I think can be really helpful as well.
I love that because I think, one of the things I wish I would have known on my fertility journey was understanding some of the decisions I made and how it impacted even just the total possible budget I had to be able to try to have a healthy living baby. And I think, I just didn't realize, and even honestly, even until this call, even though I cannot emphasize enough how awesome DNA you and Megan are, that all of these nuanced conversations that play into even the like other aspects of it, like financial decision making to try to like get to the goal that you want to get to.
It's something that I know that Megan and I and every genetic counselor tries our best to like bring all those nuances into it. One piece of the discussion that unfortunately is very relevant in the United States right now is like I will have different conversations with patients who are in Texas versus California versus Florida versus New York, let alone the Midwest. Like it unfortunately is a big piece of that decision making, and people may feel more or less comfortable taking risks than they would in another scenario. So that is something that has been ever evolving and unfortunately really challenging in lots of areas of the United States.
Thank you for bringing that up. I think like I'm living in Canada. I cannot imagine. I think like having those conversations on your end, I think it's just so critical. You don't think about those risks in certain areas of the world or states. If there is someone who can't afford private counseling or genetic counseling, just what can they do? Is there any resources that you or DNA or anyone have? What should they ask their clinic for?
Yeah, no, it's a great question. So there's some stuff on YouTube that can be super helpful. I know Megan has recorded some stuff. There are Discord channels that are really helpful, Reddit. Megan I have done a couple like National Infertility Awareness Week, like AMA, and those are really rich with like very specific but broad questions where they're saying like, hey, like let's dig into this specific thing, and without getting into like a consultation to like provide kind of some of that context. I think there are some resources out there. Megan also has a Mosaic embryo like workshop on DNA that she's hosted. We are building more like pre-PGT-A consult. Like I'm making a lot of videos right now about like pre-PGT-A, like what you should know, what questions you should ask your clinic. And I do want to mention also, so for the month of June, DNA did like kind of a trial run of this Pay What You Can program. So that was targeted for the LGBTQ plus community for the month of June. And we are hoping to like continue it because I really think like everybody deserves access to genetic counseling, and like the financials are unfortunately like we got to pay bills, we got to do things. And so I want that to be available, whether they can pay, $50, $20, $100, like whatever. We want that to be available to people.
I love that. That is so awesome. I think that you guys genuinely, for anyone watching this, because we're just at time now, Emma is tagged and DNA are tagged in our Instagram posts. I think our Facebook posts too. Please message us if you want to get in touch with them as well and you can't find any other information. Thank you, Emma. This has been just such an amazing episode. I am confident people listening in on here have had just an incredible amount of wealth of knowledge, and you are genuinely awesome. And thank you for taking the time.
Thank you so much for having me to nerd out about embryo stuff for an hour.
I love it.
It's the delight of my day.
I love it. It was awesome. Thank you so much.
You bet.
Have a good night, everyone.
Have a good one.